Thank you very much. So we have prepared this lecture with the collaboration with my mentor, Podbregar Matej, who cannot be here today. Thank you. So this will be a little bit of more local lecture about how we do it. I come from 11-bed level 3 ICU. Around 40% of our ICU admissions are septic shock or sepsis. This is pre-COVID data. Now it's a little bit more than, a little bit closer than around 30. We admit all from 30 to 90 years. This is around here, but our youngest patient was 12 years old, not of the sepsis. We admit from every department in our hospital, most from the emergency ward and the internal medicine departments. The admission to our department is based on standard pre-admission criteria, clinical examinations, hemodynamic status, respiratory status, lactate, inflammation markers. Also, one cannot forget about the expressed will of the patients. And we have to tell that there is a lot of inter-doctor preference. So let's say the patient that is very young, let's say 30 years old, with the signs of sepsis, can be admitted to our department with negative lactate and normal respiratory status solely based on the tachycardia of, let's say, 130 that is present for more than 4 hours. On the admission, there is every time arterial lines, central venous. We still use a lot of EV1000 flow track monitoring. Every patient for every admission gets an echo, chest x-ray, urinary catheter, microbiology for the sepsis, and of course empirical antibiotic treatment with the pulmonary artery catheter very rarely now. This is our local steps to the septic patient. This is in Slovenian, but today we are only focusing on this part, that is the septic cardiomyopathy. So we have 3 major things to worry about: vasoplegia, cardiomyopathy, and RADS. But today we only focus on the cardiomyopathy. So in the first thing, the surviving sepsis campaign say that we use dobutamine and with the norepinephrine, and the levosimendan is suggested against. Now this will be a thing that we disagree with, and we also use it. We will talk about it more. So the incidence of the septic cardiomyopathy is around 1/3, 30%. It was first described in the 1960s, 70s, 80s, more after the Swan-Ganz catheter production. And the first thing was that the systolic function is lowered, and there is, in the Frank-Starling principle, diminished response to preload. This is the normal sepsis and septic shock. So in the fluid administration, there is no rise in stroke volume index. After that, there was a lot of talk about right ventricular dysfunction, and because of the normal filling pressures. And the important thing, the showing of the cardiomyopathy only after the starting of the vasopressors. So when the patient is admitted, there can be pronounced hypercontractility of the myocardium, but after starting the norepinephrine and the normalization of the blood pressure, it can drop very quickly. This is one of the reasons why we use the flow tract monitoring, because let's say the serial echoes are not as easily obtainable as the number on a screen. Of course, knowing the basal status of the heart. This is a nice graph showing the 4, let's say, types. In my case following, we will see going from here, this is normal ejection fraction on the admission with the vasoplegia. So the cardiac index and the ejection fraction are normal, to here, lower cardiac index with the lowered ejection fraction. The main thing of showing that picture was that the prognosis is poor in this right upper point because of the pronounced vasoplegia, but if one would only see the heart, they would say that the heart is normal. Why are we talking about this anyway? For a little bit only a word about the right heart dysfunction, it is now very well known that the isolated right heart dysfunction also exists in septic cardiomyopathy and is by itself a negative prognostic marker. Of course, we all want to improve the cardiac function, and the positive test with the dobutamine, with the inotrop, is one of the positive prognostic markers that is a thing to remember. So in the treatment, we have three basic options. There is dobutamine, that is beta-1 agonist. We have levosimendan, and we have milrinone. We use all of the three, but a lot of the talk about personalized medicine, we always gauge which one to use. So for the dobutamine, this is the first line. Dobutamine we use with the septic shock that is, let's say, isolated. So no prior cardiac dysfunction, no prior known vessel disease. The next one, milrinone, phosphodiesterase inhibitor, we use mostly when there is known vascular disease prior to our admission. So if someone has known vascular disease, we wouldn't use dobutamine because of the increase of the oxygen consumption, but would go for the milrinone. And the levosimendan, that was before, let's say, advised against, we cannot totally agree with that. So the problem is, as we all know, the systemic hypotension, but in the combination of septic and cardiogenic shock, let's say for the patients that has lowered ejection fraction on the admission or known, we use levosimendan quite often, not as the first line, but let's say after 2 days of treatment. One maybe difference than the manufacturer recommendation for dosing is that we administer it in the much lower doses than is recommended. So if the recommended dosing is with the bolus, we never administer it and start at the 0.01 micrograms per kilo per minute and leave that for the first 24 hours. And then slowly increase the dosage so the complete 12.5 milligrams can be administered in 72 hours or more. Now a quick case that was not long ago. So we have admitted a 46-year-old female patient, no prior illnesses, no basic therapy, no allergies. She was in emergency ward for about 4 hours. First thought that she had a brain injury or brain infection because of her very altered mental status. She couldn't speak, was somnolent, only sleeping with kind of a lowered blood pressure, but she was not hypertensive before. She became ill, a little bit tachycardic with normal saturation. Her inflammatory parameters were elevated and lowered. The CT scan was non-significant. Lumbar puncture was non-significant, but she was in any case started on ceftriaxone and ampicillin in the case of meningitis. After that, she was admitted to the infectious disease. There, she was another 4 hours. She received 6 liters of intravenous fluids with precipitous hemodynamic collapse. She was started on vasoactive support with dopamine. Just one sentence here. It was infectious disease department, and if there is one recommendation, it's the use of noradrenaline, but because of the historical reasons in our hospital, some doctors still use dopamine. But very quickly, she was transferred to the ICU after getting lactate of 8.3. On the admission, continuous hemodynamic deterioration. She received all of those arterial lines, EV 1000. She was anuric at that point, but her cardiac index was high. Echo was actually normal with hyperdynamic contractility of both ventricles, but on the abdominal ultrasound, there was the left side hydronephrosis. Now, why is this important? As we remember from before, she was admitted with no abdominal pain. And the consultation with the radiologists for the ultrasound of the abdomen was at emergency level, let's say, denied. There was very quick diagnosis of nephrolithiasis and then the placement of the double-J catheter. After a couple of hours, her cardiac index began to drop, so we have moved from this right upper level to down here. And she was then started with the dobutamine. She was stable over the night, never intubated. Her respiratory function remained all the time perfect, even though she was on vasopressin and dobutamine and noradrenaline in the high doses during the first day. The vasopressin was discontinued very quickly, and also dobutamine was discontinued because the control echo was, let's say, almost normal. There was a diagnosis of the E. coli urosepsis and normal cardiac index. The third day, again, the drop in the cardiac index below 2 with lower normal blood pressure, heart rate of 110. So we have moved from here on that picture to up here. Let's say not the cardiac index was not normal, but she developed tachycardia. So her central oxygenation began to drop, and on the echo there were the dilations of both ventricles and the impaired function of the right and left ventricle. She was restarted on dobutamine in the low dose. Her cardiac index improved, also echo improved. I don't have the pictures from the first day. This is the third day. Again, with the decompensation, with marked systolic dysfunction, and also marked mitral regurgitation with the dilation of both ventricles. The fourth day, she was stable. Dobutamine was discontinued once again. Echo was marginally improved, but we tried to keep her off the inotropic and vasopressor drugs so we could start with the physiotherapy on our department. The serum lactates were negative all the time, and this was, let's say, marginal improvement in the function. She remained with us for next 5 days without any support. Why? She was transferred to the urology department, the surgery department, and we have talked with them that she will be transferred only after the complete resolution of her symptoms. So, gradual normalization of cardiac function and morphology with very prolonged cardiac depression that lasted almost 8 days. So this is longer than, let's say, 4 days that is reported in the literature. 2 days before transfer, still pronounced mitral regurgitation, and this is on the day of transfer, the cardiac echo was completely normal. So for the take-home points, the septic cardiomyopathy is very common. We have to look for it, or is it echo or invasive monitoring? Doesn't really matter that much, but we must get the data. So we have 3 options in the treatment: dobutamine, levosimendan, and milrinone. We would advise to use each 3 for very specific cases, and it can be very prolonged, so the continued monitoring is very important, and of course source control is at the pinnacle of the treatment. Now I would like to thank all of you, for Zoltan for invitation, my mentor, Professor Podbregar, and all of you for bearing with me as this was my first lecture at this international level. Thank you very much.